sterile water everything?
That's a good question, because like for a TURP patient, they have, the reason they're bleeding is they have venous sinuses that are open in the prostate. And if you infuse sterile water under pressure, it can get into the bloodstream and cause hemolysis.
TURP?
Yeah, exactly, TURP. Yeah, actually worse than TURP. It can cause hyponatremia, but it can actually hemolyze the red cells. Those are two kind of different. TUR syndrome and hemolysis are sort of two different things. So what I wanted to talk to you guys about, I don't have a handout, is just some sort of nuts and bolts things about taking care of these irrigation sets. The first thing is you want to know why the irrigation is in. Not because the patient has bloody urine, but specifically why the catheter is in. And I'm not going to talk about the difficult ones, but the easiest one is your 80-year-old man who's, say, he's had prostate cancer, and is on Coumadin, or a woman who's on Coumadin. They come in and they have gross hematuria. They come through the ER. They get this three-way setup, and you just want to keep irrigating them. And I'm going to talk about that one a little, because that's one where you're not going to hurt the patient by irrigating them. I think one of the big impediments to doing the irrigation and doing it effectively on the floor is that you're afraid you're going to perforate someone's bladder. And if the bladder itself has not been operated on, you're not going to perforate anybody's bladder. If someone's bladder perforates while you're doing this hand irrigation, you didn't perforate it. There was something really wrong with that bladder, so you're just not going to see that happen. But somebody who has had bladder surgery, like they've had a suprapubic prostatectomy, which we don't do that many of anymore, or they've had a bladder biopsy or a bladder tumor resection, is at risk of getting their bladder perforated. You really won't see the bladder tumor resections, except for some of mine, maybe with these three-way catheters. So, yeah, radiation cystitis. I mean, we had Mr. Holmes up here, for what, 2 months or something. Everybody knows him, right? It's not a HIPAA. It's not HIPAA protected. We all know. So he was a great learning patient, right? Because every aspect was there with him. But even though he had pain with the irrigation, you didn't hurt him. So, and that's important to remember that. So the first thing you want to do is you want to look at the catheter, and who can tell me what the catheter size is that can be expected to get clots out? How big a catheter do you have to have? Bigger, 22. Yeah, 22. 20 is, if a 20 works, it's okay, but if it doesn't work, then you could go to a 24. So 16's no good. Patient comes from the ER, 16, you got to call somebody and say, I can't, this patient's got clots in his urine, I can't get the bladder empty. So you look at the catheter, and then you decide if it's on CBI. Ray probably talked about this. If what goes in must come out, and I wouldn't worry a whole lot about measuring, it'll say strict INOs on the orders. I wouldn't worry a whole lot about that. We're more interested in the plumbing. We don't even look at those numbers in the morning. I'm not going to say, well, I want to know that you put in, 2.6 liters and the patient 3.6 came out. We're not going to do that. It's just not going to happen. So so what goes in must come out. That's really important. This is why you're still assessing the patient. And then the third thing that you want to know is you want to ask yourself, what's wrong? So what's a scenario where something's wrong with one of these?
You don't have any output.
You don't have output. Okay. And the patient is pain and right. And so you turn the irrigation up all the way to get output, right?
No.
No.
Okay. So you give them pain medicine, right? So you irrigate them. They need pain medicine when you irrigate them. So the orders will say, you see the orders sometimes, they say, ensure patency of catheter before giving pain medicine. So if you check the catheter, if you hand irrigate it, it's not patent, and you're going to have to irrigate them, they're going to need pain medicine, or you're not going to be able to irrigate them, and then you're going to get scared. Okay?
But usually the pain is caused by the blockage, pressure.
It is. So if you can sneak in there and go like that, bam, and it comes out, the pain goes away, right? Then you're the hero nurse, right? Then I hear about you in the morning. How good you are. Sometimes I hear other stories. I don't know what was going on last night, but all these people coming. So then the next thing you want to know is what can you do? And it's almost always clots in the catheter. It's not the catheter's leaking. There's no such thing as a leaking catheter. When you see leakage around, and Ray probably mentioned this, when you see leakage around, like in a male patient, around the meatus, at the catheter itself, it means that the urine is trying to find its way out, and the catheter is clogged, and it can't get out through the catheter, so it's going to go adjacent to the catheter. It has nothing to, so you don't want to play with the balloon and reposition it or any of that. You want to get that catheter working if you can get it working. Just lost my train of thought. That's all right. Oh, so then you have to give them pain medicine, and then you want to irrigate them vigorously. I'm going to ask this question. I'm interested in what the answer is because I thought about this last night. Choice A or B. The bladder is a sphere that stays like this all the time, or it's a collapsible and then filling thing. B. So in a collapsible bag, if you apply suction with the catheter, so you put a little bit of fluid in and you apply suction, what's the catheter going to do? Yeah, and then you say it won't irrigate. So you have to make space to irrigate, and that's what the bladder is supposed to do. So we know that as urologists because we're looking inside of. That's what I was just doing. We're looking inside of bladders all the time, and you just can't. You can't do anything if the bladder's collapsed on itself, or if there's clot in there and you're sucking the catheter against the mucosa, then you can't do anything. So this is where it gets. This is what makes you guys sweat. And then you have to irrigate the catheter. If the patient's in pain, you're making more pain when you're irrigating. When you're thinking, I'm going to rupture this guy's bladder, then I'm going to have to call the urologist, right? Not going to rupture anybody's bladder. But if you have a doubt about that, then I would call the urologist and say, I checked the catheter. I think it's occluded. Can I vigorously irrigate this guy and try to get the clot out? And the urologist would say, yes, please, because it's 2 in the morning. I would like to avoid that. So that's kind of if you've done all that stuff, then your phone call makes sense. But if you and I think everybody does a really good job of that. But occasionally we'll have a float person who's working on 6 North, and they'll say they irrigated, and I get a feeling that they're not that comfortable because I know they're afraid, and the patient gets very anxious. Their heart rate goes up. They're having spasms, and the only way you're going to get that relieved is to irrigate them. So changing catheters is pretty unusual. The need to change, unless you're changing to a larger size or this thing's really got some nasty clots in it and you can't get the clots out of it. But you should be able to, if it has clot in it, through the big port, right? I know Ray just talked about this. You should be able to blow the clot back into the bladder. Then the other thing I would tell you as a tip is you want to be as comfortable as you can when you're doing this irrigation. So 2 liters of saline, one of these setups, at a height where you're not like bending over and struggling, and the patients have their pain medicine, then you're all set to irrigate.
Are we allowed to, sometimes when we hand irrigate and then we can't get, you can't pull it back, and we suspect that it might be caught in the bladder wall.
Yeah.
So are we allowed to deflate the balloon?
You can, but I don't think it's going to make a whole bunch of difference unless the balloon is kind of got a clot sort of in the corner of it. But yeah, if you want to do that, just make sure it's still in the bladder. So did Dr. Roberts tell you? He talked to you about how far to. He probably gave a better talk than Jerry's probably done, but he told you how far to put the catheter in, right?
Yeah.
All the way to the Y?
Not just until you see urine and then you blow the balloon
Yeah.
up?
Yeah.
Okay. Did he tell you where to look when you're blowing the balloon up? Look at the patient's eyes. Always look at the patient's eyes. Because if it's on a male patient, if it's in the wrong place, you'll see them. And if you're meeting a lot of resistance, and you'll sometimes you'll see this kind of backfill a little, and you'll see the balloon kind of this will expand. That means you're meeting a lot of resistance. It doesn't always mean that. It may just mean you're filling it really fast, but you may be blowing it up in the prostate, and then that catheter isn't going to work. So if you blow one of these up in the prostatic urethra, the patient's narcotized enough that they don't react to it, and you try to irrigate them. What happens when you irrigate one that's in the prostatic urethra? Does it work? Does it irrigate? No, it comes back, right? Because it's filling in the prostatic urethra. It can't get into the bladder, and it just comes straight back. What else?
Difference between the hematuria catheter and
Oh,
regular catheter.
just that the hematuria has that spring wound in it. Is it one of these?
I think
My
it's
glasses on. Yeah. This one's just stiffer, and the reason it's designated as a hematuria catheter is so that when you're applying suction back, no, that one doesn't have the spring in it. No huge difference. They're a little bit stiffer so that when you apply suction back, they don't collapse. And yeah. So, can someone give me a little talk on Coude catheters? A brief bullet.
Dr.
Robert's
Robert's
talking
talking
about
about
it.
stiffer, like a zipper.
Yeah.
Should be up in here, so.
Not always. Did you talk about twisting it?
No twisting.
He said don't twist.
No
Yes.
Then keep it up.
Yeah.
Just
Like
one.
but the regular one you
Straight
twist,
line.
not the
Okay.
coude.
He
All
said
right.
twist the other
When
way.
he said when you insert it, the tip should always be up.
Should be.
Yeah.
And then no twisting.
Can I modify that just a little bit?
Oh,
Just a little bit. So,
look at that.
this has no direction when you twist it. Sometimes he's talking about it sort of screwing in, right?
Yeah.
With a regular
With a regular
Yeah, I
catheter.
just had an idea about that. Let's talk about that. So, with the Coude though, sometimes, it depends on what you're dealing with. Sometimes if you twist it just a little bit, it will find its way through the prostatic urethra. You won't hurt somebody with a Coude if you put it in upside down. It'll just trip on itself. That's all that'll happen to it. And you won't hurt anybody with a catheter, period. So who thinks you can irrigate with more than 60 cc's at a time?
We can.
Yeah, we
We
can.
can.
Yeah, because that's the biggest call. That's how we know right away when a nurse calls us. We'll say, well, how much did you put in? I'll say,
Yeah.
well, 30 cc's at a time.
Do it.
It's just, how much force, Dr. Dallin? Like,
Pardon me?
you know, how much force? Like, some do is like hard, some
No.
slow.
I think it's.
I think once you
Because
kind of
damage.
get it, like, this is kind of, I mean, you have to do this to really know, and you guys have done it, but
Yeah.
once you get it to go in, and you see us sometimes do
Yeah,
this?
yeah.
Yeah, so I know I've got space in there, because the patient's usually not like on this. And then you kind of just hold it there for a second, and it goes, and you see the black come in, then you know you're really doing it, and you fractured the clot. And you-
Janice and I both have calluses.
From doing that, yeah.
Janice and I both. So.
Oh, yeah.
And I always tell the patient, I'm going to hurt you less than Dr. Darling. So, so bear with me.
Hey, Doc, I'm gonna hurt you less than, I don't know what Dr. Darling did to you, but I'm gonna fix
You're
it.
quite a bit more vigorous than I'm comfortable being.
Yeah, I mean, all urologists are, and that's what the pain medicine's for, because you've got to get that clot out of there.
Yeah.
The clot's a magnet. When it's in there, and the bladder continues to bleed, it wants to find that clot. It's true in open surgery. When you stop, when you take out a bloody organ that you're removing because it's bleeding, it's kind of magical. Within a minute, all the surrounding bleeding really stops. And we don't understand the physiology of that, but it's true.
So we don't push it all the way in. We have to leave a space. Say
That's a good idea. I guess that's what we do. I never thought of that, but yeah, you leave a little space. You need a little working space, so you can kind of play with it a little bit. I guess that's what we do. I didn't think about it.
We're not actually pushing the whole
30 or 60. You have to leave like 10 cc's.
You do it by feel. If you push it in, the guy just looks at you, then put more in. Because you want that space inside the bladder. If you don't have space, you're inside the bladder trying to, exactly. You're in there like that, and that's not going to help you. You want to be in something that's like that, and then you can freely urinate. But you're certainly not going to hurt anybody with the catheter. With the right catheter that's well placed, you're not going to hurt anybody. And if then you can confidently call a urologist and you can say, and always tell them, this is a 22 French three-way. The patient's bladder feels a little distended. I want to irrigate it by hand a little bit more vigorously, and just, if it's not working, can I give him some more pain medicine? And do you have any suggestions? And you may say, put in a 24, put in a 26. Questions?
We can irrigate on the three-way. Can irrigate on the three-way.
Absolutely. Yeah, absolutely through this port, right? You can push, this won't irrigate back, you won't hurt anybody, but you can actually, sometimes if you think the catheter is not working, you'll see us put the piston tip syringe on this and push through it just to make sure that the in is not clogged. And then But this is obviously the working part right here. So did he talk about lighting and gelling?
A little bit.
It's really dangerous, right? Super dangerous?
Yeah.
You didn't say
It's your friend. It looks scary, but it's your friend. Yeah, we want to use lighting and gelling. Do we have a?
They took it away from us.
They took it away?
Yeah.
We still do have it sometimes.
No, but we have to order.
Yeah.
I got an order from pharmacy. Yeah.
So you guys I would use it on every patient that you put a Foley in.
Yeah, but you have to get an order.
I know it's an order, but we have it in the patient.
So when we put it in, yeah, we'll have to do that right, because sometimes, you know, the nurse will get the red and white tube instead of the UroGen, the injectable. Has to be on the order.
Yes.
Yeah.
I don't think we have an order for that, sorry. We do? What's it called?
UroGen.
UroGen. Oh, it is?
Lidocaine.
Yes.
UroGen.
So if you add it to the.
What is that?
Maybe talk to Gretchen about adding it to urology.
Be awesome. That'd be great. We'd help you guys. B&O suppositories, did you talk about those at all?
No.
So so who wants to tell me what they're for?
Bladder spasm.
Why they work, nobody really knows why they work for the bladder, but they work. But they work.
They want us using it all the time,
I
you
think,
know?
yeah, I think so. If we're gonna use them, we should really use them. So, big catheters, pain is usually that they're obstructed. Catheters really don't leak, it's that they're obstructed. What else? Saline, we talked about that. There's some differences, obviously.
Between saline and a sterile water, why do you use?
You just-
Because they get hemolysis with sterile water. Some urologists will use it, but it really should be saline just to be safe. And then you'll have the differences among specialists, and that's what you guys just love. Because one person does it one way and one does it. Some of my partners will only use this thing. Only use this thing. And they absolutely hate these. Yes, they hate them.
Right.
Correct?
Yes.
Others will only use these, and they don't like these because these work, but you talked about the clamping, unclamping, use this.
Yeah, but we use that for IVI
Yeah,
only.
it's easier because then you're there, right? Yeah, this is good for
So we
IVF.
have, usually when we hand read it, when we disconnect that.
Oh, you do? Just go straight on.
Yes.
Okay.
Yeah.
Okay. Any other questions about anything? So you guys just want to, did you have questions?
No.
Syringes. Every time we do irrigate, do we have to change the syringe? Is there any sterility involved or something?
No, not really, as long as you keep this stuff, you know, yeah, as long as you keep it.
Yeah, we have a surgeon in the past, there was a doctor who always loved the sterile.
Oh, was that Bob
mustard
Masters?
test.
Yeah.
He retired already.
Yeah.
When you put Foley's in.
Because
He
you
did
irrigate
what?
like
You
every.
wear gloves when you put Foley's.
Are you serious?
He uses like a forceps or something.
Really?
My sister let me use the forceps and I use it and use all that and this is the forceps and insert it.
Those are the differences.
Yeah.
Well,
The county committee, they actually are rolling out that you have to change
This?
every time you irrigate.
If you irrigate every hour, like every
They
40
want you
minutes.
they want you to change it every time.
I know, it's
Yeah,
It's like
what's the committee?
It's the county committee, it's for the catheter-induced urinary tract
You know
infection.
how you guys are affected?
What's COTI stand for?
The catheters is
urinary tract infection. So there's a lot of things
So
like they have to
like-
break the seal on a catheter. We had
The
a
police
nurse
on the
float up
catheter.
from 5 North who was trying to irrigate from the specimen port.
Yeah.
But that's what the Mosby book tells him to do
Right.
when he looks it up. So
So-
that's the,
Oh, right. Really?
yeah.
So urology patients are technically removed from, they're trying to roll out a protocol, so for like non-urology patients and abdominal surgeries, we can remove catheters before the orders. And you're not part of that, but they're trying to say that by not changing the syringe, we're gonna introduce new organisms.
Yeah, I get the argument. I mean, it's technically right, so, I mean, if that's what they're telling you to do it. Because you'll have somebody.
They're also saying don't break the seals on catheters and, Dr.
No, but we can break them.
Some of them like to just let the catheter dangle while they're showering. So a lot of the things that you guys do, a lot of